We'll go through another high-yielding domain. Mainly, you get questions on IABP in CBS, but you can do get questions about IABP in CCS. So you have a case, something to do with cardiology, cardiogenic shock, or acute MI. So you can still be asked about IABP there. But most commonly, you'll get it in CBS. Okay, and it's a very high-yielding domain and very easy to answer, very high scoring. So we'll just go through how to approach a question on IABP. So today's agenda in this talk is first we'll discuss a little about the hardware and monitor. Sometimes you get questions on the monitor, they'll ask you about the waveform and all. So we'll discuss the IABP arterial waveform, what is the physiology of it, so what are the indications and contraindications for initiating IABP, what are the complications you expect. So any intervention you do or any procedure you do in ICU, so they expect you to know about the complications. Next, coming to the errors in timing, that is the most commonly asked question in CBS, the errors in timing of your IABP waveform. Then we'll discuss about the evidence and we'll discuss a few commonly asked questions as well. So this is the console diagram. So this is how your IABP machine looks. So this is the front of the machine, how it looks. You have a display here which shows all the waveforms. So we have a interface which is help you to make a lot of settings. I'll show you those settings, how we do it. So next is uh, this back of the console, so which has a fiber optic sensor module, helium tank, so and a few other connections as well. So this is how it looks. So this is how the IABP balloon is positioned. So we all know it has a radio opaque tip, a balloon, and this is on a catheter. So usually we put this catheter through the femoral artery, so either the right or the left, most commonly the right, and this is how it is positioned. So you position it just distal to the left subclavian artery, so it doesn't occlude it. And the lower end should be above the renal artery, so it doesn't occlude the renal arteries. Okay, how to know it? So we'll discuss further. So this is the arch of aorta. So this is your descending thoracic aorta where the balloon is positioned. This is the catheter which is carrying the. So this is how the interface looks. So we have multiple waveforms. So the common trigger which we select is our ECG. So you see it in green and it is on the top of the screen. So next is your arterial waveform. So this is the augmented waveform. So this is how it looks. It can be of different colors, but so this is the common color. Sometimes we do select it in red color. So you get the pressure waveforms here, systolic pressure, diastolic pressure, and the augmented diastolic blood pressure. So this is the arterial trace waveform. So, and next is your balloon pressure waveform. So how is the balloon getting inflated? So this is how the balloon waveform looks. Okay, so this is the balloon pressure waveform. So next is the operative mode. So here we have the, whether it is auto mode, what is the mode. So next we have the trigger options. We have the IABP frequency. We have the augmentation level. So we have the positioning of the inflation and deflation. So whether you should make it early or you should delay the inflation or you should make early deflation or late deflation. So this is for the timing of the deflation, timing of the inflation. And we have a standby switch and a start and stop switch. The standby switch is mainly just before we remove the IBP or sometimes used during the weaning of your patient from IABP. So this is the common trace waveforms, and you can see a small cylinder which is shown here. This will show the level of the helium gas. So you need not have a full cylinder, and even if the cylinder is near empty, also don't need to worry about it because we are not giving oxygen. It is not like, I mean, we are not giving helium to the patient. It's not like oxygen cylinder where it can get exhausted. So whatever goes in comes back again. So no need to worry about it. Okay, so this is the helium cylinder which is seen. Okay. So this is in detail about the console and the waveform. So we have seen this is the waveform. So this is the main waveform which we're talking about. And always remember, we can only interpret the waveform if it is in 1:2 or 1:3 augmentation. Don't try to interpret the waveform in 1:1 augmentation because you will not know which is the augmented portion, because you will not know the effect of your IABP on the hemodynamics of your patient. So it is only possible by putting it in 1:2 or 1:3 mode, not in 1:1. If somebody asks you to say, I mean, definitely not be a bedside. So if at all in your bedside, say in your other exams, if they ask you to interpret the IAPP waveform, you should put change from 1:1 to 1:2, and only then you'll be able to interpret or to know the physiological effects of your IABP. Okay, so this is your regular arterial trace. We all know this. So this is your unassisted diastolic blood pressure. So this is an unassisted systole. We have a dicrotic notch, and after that, it comes to the unassisted diastolic part. So when you have IABP balloon, and this is the assisted portion. So we all know inflation happens during the T wave of your ECG. Okay, I'll tell you the details a little later. So this is how your waveform comes, and your inflation should happen at the dicrotic notch. And what is the next upper limit of the waveform you get is your augmented diastolic pressure. So this is what we are mainly worried about. So this is the augmented diastolic pressure, which happens following the inflation of your balloon. So next, after this waveform gets completed, so you get the next peak. That next peak is your assisted systolic. So this was the augmented diastolic. So this is your unassisted systolic. So this is your assisted systolic. So after being assisted by your IABP balloon, so you get the next systolic waveform, which is less than the unassisted systolic. So this is your assisted systolic pressure, which is less than the unassisted systolic pressure. Okay. So after that, the waveform continues. Okay. And before that, before you get this assisted systolic, you get this assisted diastolic pressure, which is less than the unassisted diastolic. So both your assisted systolic, assisted diastolic, both will be less compared to your unassisted systolic and diastolic. And you get a augmented diastolic pressure. So this is only possible when you do it in a 1:2 augmentation. Okay. So this is how it looks. So this is the rest of the tank. I told you helium tank. We use helium. Why? I mean, sometimes you can get questions about why helium is used. So helium is used because it's a less dense gas, so it can easily go in and come out. And even if there is any error in the balloon ruptures. So helium is a very soluble gas, so it can easily get dissolved in the blood, and it doesn't form a air embolism. So there's no risk of air embolism even if the balloon ruptures, and it is a very, very less dense gas, so it can easily be inflated and deflated. The balloon inflation and deflation takes very fast. Okay, so that is why we use helium. So this is the magnified version of the waveform. So I told you this is the arterial trace. So this is the unassisted diastole. So this is the unassisted systole. So this is the dicrotic notch. So your balloon is inflating here, and you get a diastolic augmentation. So this is your assisted diastolic pressure. Next waveform you'll get the assisted systolic pressure, which both of which are low, and you can see where is the inflation happening by looking at the IABP balloon pressure waveform. So this is pressure waveform is the IABP balloon pressure waveform, and this is the duration of your IABP inflation. Okay, so this is the time it gets inflated. So you get the peak of the IABP pressure. This is called overshoot. Then you have a plateau, and then it comes, and during this is the deflation of the balloon. Okay, this is a balloon waveform. So this is in particular about the balloon waveform. I told you this is your balloon overshoot. So balloon rapid inflation, balloon overshoot, balloon plateau pressure, where there is equalization of the pressure, and rapid deflation. So this is balloon deflation. Again, it will return back to the baseline, and again go to the next inflation. Okay, so this is inflation deflation. This is only the balloon pressure waveform. The previously we saw the arterial pressure waveform. This is the balloon pressure waveform. So now looking into what happens during the cardiac cycle, I told you usually the common trigger used is your ECG trigger. So this is your ECG P, Q, R, S, and the T waves. And you can see when is the inflation happening. You can see that inflation is happening at the T wave. Okay, so at the onset of diastole, IBP inflation occurs, giving rise to a sharp V. So I told you at the dicrotic notch, we'll have a sharp V. That is when you'll come to know that is accurately timed to the dicrotic notch. That is the aortic valve closure. When the valve is closure, you'll have a inflation. I mean, you'll have a sharp V on the arterial trace when there is IABP balloon gets inflated. Okay, so you can see it in the picture here. The IABP balloon gets inflated. You'll see the diastolic augmentation happening. So this A is the entire cardiac cycle. B is the unassisted aortic end diastolic pressure. I've already told you unassisted. So this is the previous waveform which was not assisted. So this is the end diastolic pressure of the unassisted waveform. C is the unassisted systolic pressure. I told you this is the dicrotic notch where your balloon gets inflated. D is the diastolic augmentation. E is the end diastolic pressure of the assisted waveform, and this is your assisted systolic pressure F. So though it is not labeled here, you have the reduced systolic, and you can see that your diastolic pressure as well as systolic pressure of the assisted is less than the unassisted. Okay. So next comes the point of deflation. So this is at the E wave. So just before your heart starts, this is the point of deflation. So now let us look into what are the physiological effects of this. So by inflation at the dicrotic notch, it will lead to increase in coronary perfusion. So it will increase the diastolic pressure. So we all know that coronary perfusion happens during the diastolic part of the cardiac cycle. So there is increase in the coronary perfusion. So by deflating at before the start of your systole, so what are the hemodynamic effects or what are the physiological effects of it? It will decrease the workload. So suddenly there is deflation of the balloon, so which makes the heart to easily pump the blood forward. So that is why it will reduce the cardiac work, it will reduce the afterload, reduce the myocardial oxygen consumption, and it will obviously making the heart work better. It will increase the cardiac output. So this is the physiological effect. So what happens with inflation? Inflation leads to increase in coronary perfusion. So what happens with deflation? Because deflation happens, there is reduction in the afterload. Because there is reduction in the afterload, your heart will have to do less work, and that will lead to decreased cardiac work, decreased myocardial oxygen consumption, and ultimately leading to better cardiac output. So this is the physiological effects of your IABP balloon inflation and deflation. Okay, we saw the timing, we saw the physiological effects. Okay. So now let us go into each parameter, how to set up a parameter on the console. So this is how your interface looks. So we have something known as auto mode and a semi-auto mode. So auto mode, when you're not sure how to start it, how to, what trigger to select, how to select and all. So you can just put it in auto mode. It will only automatically select appropriate ECG and it will start supporting. In semi-auto mode, you'll have to give some feedback to the patient or you should make some settings. So the common triggers we see, we can see the ECG trigger, pressure trigger. So next we have a pacer, ventricular pacer or atrioventricular pacer. So pacer A, atrial pacing. Next we have the internal mode. So let us look at each of the triggers. So ECG trigger is the preferred and most reliable. I showed you in the previous picture as well. So we'll time it according to the ECG. We will time it according to the T wave and the initiation of the QRS complex. Okay. So ECG trigger is the preferred and the most reliable. R triggers deflation. Whenever you get R, we saw that, right? So before the start of R wave, you see that the balloon gets deflated. So R triggers deflation. The T wave triggers inflation. So whenever it finds a T wave, it will inflate the balloon. Whenever it finds a R wave, it will deflate the balloon. So mainly can be used during arrhythmias or when you have AF, when the rate is very, very high. So AF trigger can be used. So balloon deflation happens at each R wave. So R wave is not disturbed in AF, correct? So that is why it is easy when you have a patient has AF on the monitor. So you can change from the pressure trigger. You can put it on ECG trigger. So it'll identify the R wave and it will uh, time the inflation and deflation of the patients of the balloon. Okay. So next coming to the next commonly used pressure trigger, whenever there is a poor ECG quality. So you did a lot of things so that this patient has some subcutaneous emphysema because of which your ECG quality is not great, or there is some pericardial collection which is leading to poor ECG quality. Then you have no other choice. Then you can put arterial line and you can trigger it to the dichrotic notch on the pressure waveform, which I've already discussed. So, and this will, you can use the dichrotic notch for triggering the inflation and point just before the systolic upstroke, there will be deflation. So best used during your CPR. So when you are doing CPR, we know you'll not have any electrical activity. So from the arterial line, it will pick up the arterial trace and it will time your IBP inflation. Next, coming to internal trigger. So it is a asynchronous set rate. It is like a default rate which is already set without any physiological triggering. It is mainly used when your patient is not giving any ECG activity or there is no arterial trace. So like in when you're having on a cardiopulmonary bypass pump, you see we don't have a proper arterial trace. So that is when you will use this internal trigger when you don't have a good ECG or a arterial pressure waveform. Next, pacemaker trigger, pacer trigger. So when your patient is on a pacemaker, so it will use the pacing spike. The ventricular pacing spike is used for inflating the balloon. Okay. So next is auto mode. I told you when you are little not, to make your job easy. So this automatically selects the most appropriate ECG lead and that will be used as a trigger. So these are the common 5 triggers which are there, and this is the place on the interface where you'll set the trigger. Okay. Next, you can see the sources, ECG, and things like that. So, and other next thing is your IABP frequency. So IABP frequency is how whether each beat should be assisted or once in one every alternate beat should be assisted or one in third beat should be assisted. So 1:1 is usually when we start when your patient is bad when you're starting IABP balloon. So that is what we start with. So we start with 1:1 frequency. When your patient's heart becomes better, when the need for IABP comes down, we go down to 1:2 or 1:3. So next is your augmentation. So you can see it is least augmentation to maximum augmentation. It has increments of 10. So each LED lights up for every 10. So 10%, 20%, 30%, 40%. So you can usually start with 100% augmentation, slowly come down based on the improvement in the patient's cardiac status. Next is the timing of your inflation and deflation. If you see that the inflation is not happening properly, so you can time it based using these keys here. So you have separate keys for inflation to make it early or late. For deflation, you have keys to make it early or late. Okay, so this is about the trigger. I already showed you about the level of augmentation. So augmentation usually started with maximum. So you can increase it in steps of 10% increments. Maximum is 100%. I told you by default, the IAPP augments every cardiac cycle. That's what I told you. Initially, we start with 1:1 augmentation when the patient requires maximum support. So it can be decreased to every other, that is 1:2 augmentation, or every third cycle, that is 1:3 cycle. Timing and adjustment should be done in 1:2 mode. That's what I told you. So all these adjustments or interpretation of your IABP should be done in 1:2 mode. That is when you'll come to know the previous unassisted and the present assisted. So only then you will be able to interpret it and make the adjustments on that mode. So how do we decrease the supports once your patient is becoming better? So 1:1, we come to 1:2, 1:2, we come to 1:3. Then slowly we wean off the patient. So never you should put your IABP in standby. That is what commonly done practice. When you put the IABP on standby, the balloon stops inflating. So you'll have a foreign body in the vasculature. So it can lead to thrombus formation. That should not be done. So you can bring it to 1:3. And when you see that your patient is hemodynamically stable, you can plan removing the IABP catheter. Don't put it in standby mode. Okay. So how do we decide what balloon to use for whom? It is mainly depends on the patient's height. Okay, so because we are positioning the balloon at a particular place, so it depends on the patient's height. So if the patient's height is less than 5 feet or less than 152 centimeters, the recommendation is to use a 30 cc balloon. Okay, the capacity of the balloon should be 30 cc. If the patient's height is between 5 feet and 5 feet 4 inches, that is 152 centimeters to 162 centimeters, the balloon capacity should be 40 ml or 40 cc. Anybody more than 5 feet 4 inches, okay, so the balloon capacity should be 50 cc. Okay, so you decide the size of the balloon based on the height of the patient. So I told you, you should position it between your left subclavian and the renal artery. Okay, you should not, if you push it distally, if you push it more proximal to the heart, it will occlude the left subclavian. If you keep it less, if you don't push it too much inside, it can occlude the renal arteries. So this is, I've not put a normal IABP position. So this is the common way to see the position of your IABP tip. So you can all see there are multiple hardwares here. I will not concentrate on those. You can see the ideal position should be to keep the tip at 2 to 3 centimeters from the original left subclavian artery. I told you it should be at the level of the carina. Okay, the tip should have been at the level of the carina. So you can see this catheter has gone too much inside. So you can see how to confirm it. You can feel the pulse on the left left radial. You'll see that the pulse is weak or absent there. So in this picture on the right side, you see that the tip is too low. So it will be occluding the renal artery here. And so this needs to be positioned. You should advance it a little more further. Here it should be withdrawn a little outwards. Okay. So I've already discussed the physiological benefits, so I'll just revise it again. I told you, so it will support the coronary circulation, reduction in left ventricular stress and reduction in the cardiac workload. So it will increase the left ventricular ejection fraction, increase in cardiac output. You should know this. They'll ask you about how much is the increase in cardiac output because each mechanical circulatory support device can increment the cardiac output by different numbers. So how much benefit you get from IABP? It can give only up to 0.5 to 1 liter per minute will be the increment you can expect in the cardiac output by using a IBP balloon. So what happens to the Starling's curve? So it will get shifted to leftward, means which will make the LV function better. So that's what it means when you shift the Starling curve to left side. That means that the left ventricular function is becoming better. So what happens to LV diastolic volume is reduced due to systolic unloading, and peripheral blood flow also improves because there is improvement in the cardiac output. So what happens to the RV? So remember, there is no direct effect on the RV, but it can indirectly help in offloading of the struggling RV. So by reducing the pulmonary artery pressures, following reduction of the end systolic pressures on the LV. So no direct effect on the RV. Indirectly, by helping the LV, it will reduce the pulmonary artery pressures. That is how it can benefit the RV. So after knowing about the console, how to set the machine, how to interpret the waveforms, and seeing the physiological benefits of it, now let us look at what are the indications. When do you consider starting IABP for your patient? So it is mainly a temporary support of the LV function. It can be when your LV is not doing good, like in cardiac failure, or due to myocardial infarction, or due to intraoperative injury. So that is one of the common indications. So whenever you want to improve the oxygen supply demand balance or to decrease the extent of ischemic zone, that is when you'll consider starting these patients on IABP. So most of the common conditions are severe unstable angina or myocardial ischemia, cardiogenic shock, which can be because of myocardial infarction, myocarditis, or cardiomyopathy, acute LV failure after cardiac surgery, failure to separate from cardiopulmonary bypass, establishment of a preoperative patient. So you have a patient who's already has ventricular septal defect because of an MI and now going for surgery for treating this defect. So you can start this patient, stabilize this patient by starting him on IABP, which is one of the class a better indication. Mitral regurgitation following acute MI. So any complications following your acute MI. So IABP has a role when you're treating these complications following an acute MI. Stabilization of the patient for non-cardiac surgery. So procedure support during high-risk coronary angioplasty. So that is what commonly used, correct? So whenever you have a patient You're taking him for a high-risk coronary angioplasty, who are anticipating this patient can have a stormy course during the angioplasty, so you start them on IABP. Intractile arrhythmias due to myocardial ischemia, and also as a bridge to transplantation. Okay. So what are the contraindications? So you should know the absolute and the relative contraindications. So absolute contraindications, whenever there is aortic regurgitation, you can't use the balloon. So dissecting aortic aneurysm, you can worsen the situation. Large AV shunts, and those patients who are there are no chances of them recovering, and you don't have an option of heart transplant, then those are contraindications. What are the relative contraindications? Because I told you the access is through the femoral artery. So when you have a bad peripheral vascular disease, that's a relative contraindication. Aortic aneurysm, severe non-cardiac systemic disease, or massive trauma. These are all relative contraindications for IABP. Now, I told you any procedure, any intervention you do, you should anticipate a question on the complications. So, and always try to classify them or into different ways. Say, for example, during the procedure, after the procedure, before, so something like that, so that you will get multiple answers for it, and you would have covered most of the answers expected. So let us look into the complications. During insertion, what are the things? So failure to advance the catheter. So there can be a severe atherosclerotic disease in the femoral artery. So you may not be able to advance the catheter. That's one of the common thing. So there can be risk of aortic dissection, malpositioning the catheter, which is very, very common. So accidental femoral vein cannulation and damage to the local structure. So you can damage the local structures. There can be hematoma, injury to the femoral nerve, AV fistula formation. All of this can happen. So during use, I told you thrombosis is very high risk. You are putting a catheter into the patient, and you are you are precipitating it to a risk of thrombosis. So anticoagulation is usually advised. Peripheral embolization and end organ ischemia. So there can be thrombi formed on the balloon, and it can get dislodged and form embolization. Incorrect positioning leading to occlusion of the left subclavian artery or the renal artery, which are very, very common. Perforation of the balloon can happen. Infection can happen if you're handling the catheter in an unsterile way. Balloon rupture can happen. Gas embolization can happen. Because there is movement of the balloon, very high risk of hemolysis and thrombocytopenia can happen. Peripheral neuropathies can happen, and there can be errors in timing. So after removal or during removal, there can be bleeding because you have put a big catheter in the femoral artery. You should take care of the hemostasis. Hemorrhage can happen. Pseudoaneurysm can happen. AV fistula can happen. Sometimes you can see that the balloon may not come, can get stuck inside also. So these are the common complications which you expect in your patient whom you are initiating on IABP. So correct timing. So if inflation deflation are not synced with the patient's cardiac cycle, what will happen? It will worsen the already dysfunctional. I told you IABP were mainly initiating to support the LV, but if you have not correctly timed it, I told you you have not timed the inflation with the dicrotic notch, or you have not timed the deflation before the systole, then it will lead to further compromising a LV function. A correctly timed IABP should result in arterial waveform that shows I told you. So how do I know? So look at the waveform, see that at the dicrotic notch, you have a sharp V shape. The slope of the augmented diastolic pressure should be parallel to and reach. I'll show you the picture. So this is how it is. So you should see that the waveform initiation happens at the dicrotic notch. You should get a proper V here. This slope should be parallel to this slope uh, here. Okay, so these two things will help you to identify it. And I told you your assisted systolic pressure and the assisted diastolic pressure should be less than the unassisted ones. And this assisted end diastolic pressure should be at least 20 millimeters lower than the unassisted end diastolic pressure. So this is how it looks. I told you, so I have put both the diagrams so that you can understand it better. So it is very easy. So what are these are the questions you will be asked in your exam. So they'll give a waveform like this and they'll ask you to interpret. So pretty easy. So I told you there is no V here. So what does it mean? It means that the balloon is getting early inflated. So what are the problems because of it? So after identifying the abnormality on the waveform, they'll ask you what is the effect of it on the patient's hemodynamics. So you'll see that there will be premature closure of the aortic valve, which will lead to increase in left ventricular end-diastolic volume, end-diastolic pressure, pulmonary capillary wedge pressure. So all of which will lead to increase in the afterload and LV wall stress. It can lead to aortic regurgitation. It will also lead to increase in myocardial oxygen demand. So this is the expected physiological effects of early inflation. Okay. So they'll ask you what is the abnormality in the waveform and what is the physiological effect of this abnormality. So both you should know. So again here, so you see that there is inflation happening, but this inflation happening is too late after the dicrotic notch. So what is the problem here? There is late inflation. The inflation is happening very late. So what will happen because of this? There will be suboptimal coronary perfusion. I told you if there is a perfect timing at the dicrotic notch, then the coronary perfusion will be good. If it happens a little late, then it will not help in the coronary perfusion. So what do you do about it? So you need to adjust it. So you should make it to inflate little early. Okay. So next is so what is happening here? So very early deflation. So you see that it should go and come as a slope, but you see that suddenly there is drop in the pressure waveform. So what is happening here? There is early deflation of the balloon. That is what is happening. So what happens because of it? So there will be suboptimal coronary perfusion, potential for retrograde coronary flow. Sudden drop in pressure can lead to retrograde flow of your blood in the coronary arteries. Suboptimal after-node reduction because it should have deflated at the start of systole, but it is deflated even before your systole. So because of this, what happens? There is no reduction in the afterload. Because there's no reduction in the afterload, there is persistent increase in the myocardial oxygen demand. So what should we do? We should time the deflation. Okay, and you can see assisted systole is just same as your unassisted systole. Okay, so they do not do any benefit at all. And last timing abnormality, so late deflation. You see that there should have been a slope here, but you see that the slope is not there. It is come and it is taking a small curve and slowly coming down. So it is late deflation. This is how you see there will be prolonged rate of rise in the assisted systole. There will be slow rise in your assisted systole. So what happens because of this? So afterload reduction is not happening because it is the balloon is still remaining inflated when your patient's LV is contracting. So there will be increased oxygen consumption because LV is working against the inflated balloon. Okay. So, and there will be, and your balloon will impede the blood flow as well. So, ejection fraction is also getting interrupted by your inflated balloon. Okay, so this is what is the common abnormalities you will be asked in the exam about your timing of the. So it is early inflation, early deflation. So late inflation and late deflation. So other question that can be asked in your exams is what are the causes of you have set your waveform, everything is fine, the timing is perfect, everything is good, but still you see that the augmentation is not as you expected. So the augmentation is not very good. So what are the reasons? That is another question which is asked. So cause of decreased augmentation, now balloon not longer needed. Your myocardium itself has recovered well, so that balloon is not helping anything much. So that is when you see that the augmentation is not as expected. The balloon is ruptured. So balloon is ruptured, so that is another reason. And there is distributive shock. So when there is distributive shock also, you see that the augmentation is not as expected. So you get this alarm. So reduced augmentation alarm will be seen on the interface. Okay. So a question may be asked if you have a patient on IABP in the CCS, they may ask you how you plan IABP, weaning off the IABP. So very common question. So I told you start with 1:1. So taper to 1:2 or 1:3. And I told you don't put it in standby mode. So it will lead to thrombus formation. So always plan it, put it in 1:3. Hemodynamics are stable and we mix into other parameters, all like how we have weaning criteria for mechanical ventilation like that have the criteria for IABP. So hemodynamically stable, minimum supports, saturation is good, hemodynamics are stable, neurologic status is good. So then you can wean this off patient. And if your patient is on anticoagulation, you need to reverse it so that you'll be able to remove the without any much of bleeding happening. So we finished the timing. We saw the common questions which are asked. They may ask you questions about some evidence. Okay, so initial trial, which was the suggestive or favoring your IABP was IABP Shock 1 trial. So the follow-up study IABP Shock 2 found no difference in mortality because initially they said there is some mortality benefit and all, but later on the IABP Shock 2 trial said that there is no mortality benefit. So that led to the downgrading of your recommendation. I'll tell you about the recommendations which has happened after the IABP Shock 2 trial. Okay, so this is the IABP Shock 2 trial. So it said that there's no mortality difference between using an IABP or without an IABP. Okay. So next, there is another study called balloon pump assisted coronary intervention study. So they saw with the use of IABP during a PCI. So again, there is no benefit using IABP during PCI. So there's another study where they use IABP for heart failure. You can see the Kaplan-Meier curve. There's no difference between the two. So even your IABP used in heart failure for cardiogenic shock also, there was no much of a benefit in your patients who are on IABP. So this is a very late article, I mean recent article which was published in 2025. So they also saw other mechanical circulatory support devices like LVAD and all. they were found to be little beneficial, but IABP was no extra advantage. So next, another trial called Protect 2 trial. So they mainly looked into the adverse events, major adverse events with IABP versus Impella. They saw that the other adverse events were more in case of IABP than in any patient with Impella. So we all know Impella is another mechanical circulatory support device, which is very commonly used in supporting a cardiac function. So they compared IABP versus Impella, and they found that Impella had less adverse events. So these are the three major trials: the shock trial, impress trial, and the impress in severe shock. So impress in ST elevation MI as well. So mainly compared using Impella and IABP. They'll ask you this question also. So you have a patient on other circulatory support device like Impella. They may ask you what is the comparison between Impella and IABP. So they have compared, all three trials are compared Impella versus IABP, and they can see that there is no significant mortality benefit in any of them. And you saw that IABP has higher adverse event risk as compared to Impella. So now coming to what about the guidelines? So the latest guidelines was in 2025 by American Cardiac Society and American Heart Association. So they had recommended for use during acute MI. It is not for routine use in IABP in cardiogenic shock. So it was initially had a better classification, class 1, class 2. So I think before 2025, it was class 2 recommendation. After the IABP shock 2 trial in 2025, they have reclassified it and they have downgraded the class. So it comes to class 3. So that means treatment is not effective and may be potentially harmful. So they say no for acute MI and even no routine use in cardiogenic shock. Similar recommendations come from the North American and the European recommendations. In European Society of Cardiology, the last recommendation was in 2017. I told you following the IABP shock 2 trial. So they downgraded from class 2 to class 3. Okay, now the latest is class 3 recommendation. That means there is risk of harm. So let us go into little commonly asked CBS questions. So I mean, our answer is already there. I should have masked them. So due to shortage of time, so we'll not uh, keep it interactive. So suddenly you see that the catheter, there is presence of blood in the catheter. What is the common diagnosis? Common diagnosis, the balloon is ruptured, correct? Suggest balloon rupture. So how do you manage? So immediate cessation of the counter pulsation. So switch off your machine. Patient who should be put head down position so that you will prevent embolization of the gas. So IABP removal. And because this is not a sterile equipment and the gas is not sterile, so you should give some antibiotics so that your patient doesn't develop sepsis. Okay, so next question, which is commonly asked. So augmentation below limit set alarm. You frequently get this alarm saying augmentation is below the set limit. So what are the common causes for it? Common causes are either you set the alarm expectation too high, the other you are set augmentation too high, or there has been change in the patient hemodynamics. Like I told you, right? So the patient hemodynamics becomes better. So that is when you'll get the patient, I mean, the heart becomes better. You'll get this alarm saying augmentation below the limit set. So how do you manage? Assess the patient for decreasing cardiac function or worsening vascular resistance. If there is decrease in the cardiac function, then you'll have to add a inotrope. If there is worsening vascular resistance, like I told you, a patient has septic shock, there is vasodilatation, so you should add a vasoactive agent like a vasopressor. So that is when you can correct this alarm. So next, suddenly you get no trigger alarm. So IFBP is unable to sense the trigger mode that has been selected. So what do you manage? Change the trigger mode. Like I told, VCG is there. Suddenly the ECG got disconnected. So it will give a trigger, no trigger alarm. So you can change it to a pressure mode or the pressure mode. If pressure mode suddenly is not working, so you can change between the modes. Okay. So this is another commonly asked question. So because I did not put the waveform question because you all have read about it, we have already discussed in that topic. So I just asked you about what are the other common questions which can be asked in IABP. So what to do about IABP after cardiac arrest? So you get a CCS scenario, your patient is on IABP, they may ask you, now your patient has a cardiac arrest, what do you do with your IABP? So what should we do? So I told you ECG trigger becomes dysfunctional because your patient will not have a ECG waveform. So you should change it to any other mode. Okay, so most commonly, if you have a arterial trace, once the CPR is started, you get an arterial trace. You can put it to arterial mode, or you can put it to the auto mode. Okay, so one of them you can try. So pulses electrical activity, the IVP will continue to sense the organized rhythm. During compressions, there will be a significant artifact, so may not be very effective. So pressure trigger as the ECG trigger is the preferred sensing method. Like I told you, because CPR is happening, you have arterial trace. Then continue the pressure trigger. ECG trigger may not be effective. It may work when you have a pulseless electrical activity, but still with with the CPR going on, the electrical activity may also have a lot of artifacts, so it may not be properly functioning. and your patient has cardiac arrest, I should shock the patient. What to do with IABP? Don't worry about IABP. You can continue shocking your patient. Keep it in regular position, and you can shock the patient. No need to make any adjustments with your IABP. Okay. So what to do if your patient has takey dysrhythmias? So reduces the performance. So what happens to IABP performance whenever the heart rate goes beyond 110? You see that the performance of your IABP comes down. So it may not be as effective as it is when the heart rate is less than 110. So some IABP models are capable of matching rates up to 220. So if it's some new advanced machine, so it can match up to 220. But otherwise, if it goes beyond 110, you see that the hemodynamic benefits are not as much as you expect. An opportunity for troubleshooting with reduced IBP efficacy is to change the ratio. So now you can change the ratio to 1 is to 1 to 1 is to 2. So if the heart rate is around 200 or 180 and all, so then your IBP may not be effective. So what do? You change it to 1 is to 2 frequency so that it will support the alternate cardiac activity. Okay, the primary treatment for treating dysrhythmias is to treat the underlying cause. So change your IBP mode from 1 is to 1 support to 1 is to 2, and at the meantime start correcting whatever is the cause for your tachydysrhythmia. Okay. So complete system console dysfunction. Suddenly there is power shutdown or your console stops working. So what do you do that time? So the recommendation is to take a 60 ml syringe and put a three-way cock onto the catheter, and you start inflating the balloon with your 60 ml syringe. You know the balloon capacities, correct? We discussed it based on the patient height, 30 ml, 40 ml, or 50 ml. So based on that, so you start inflating the balloon, and remember this is not to support or to provide a hemodynamic support like how your IAPP machine used to give. It is not to give a hemodynamic support. It's mainly to prevent thrombosis. I told you if you leave the balloon without any action, so it will lead to thrombus formation. So my aim is to start inflating the balloon, not to provide a hemodynamic support. I want to keep inflating and deflating the balloon so that no clot is formed on the balloon. Okay. So this is very commonly asked question. And I think last question. So other complications you expect is loss of left radial pulse. Suddenly they say they put a CBS question, a big question. You see at the end it comes and says there's loss of left radial pulse. Very simple question. You will all panic seeing the size of the question. There are multiple lines, multiple investigations and all, but the answer is very, very simple. They ask you loss of left radial pulse. What is the problem? So you will that is problem is the catheter must have migrated more proximally into the arch of aorta. So that's why there is loss of left radial pulse. So what are you looking into? Look for limb ischemia. So due to either thrombosis or proximal migration. So all these are possibility. One, the catheter must have got migrated proximally, or there can be a clot which is formed there. So at the origin of your left subclavian artery. So both is a possibility. Okay. So this was about the IABP, another high yielding domain, very easy to answer if you understand the basics of it. And you will definitely be asked about it in your cardiology, mostly a CBS question, but you can get a CCS question as well.